Good evening, everybody. I want to welcome you to ASJ's 12th Live Journal Club. My name is Cindy Wu. I'm the lead Next Generation editor for ASJ. I'm really excited to bring to you tonight's Journal Club. I'd like to introduce the author of the article, Dr. Dzifa Kpodzo, who graduated with honors from the University of California at Berkeley with a BA in integrated biology. She completed a dual medical doctorate and a master's in public health at Harvard Medical School and Harvard School of Public Health. She trained in plastic surgery at the Harvard Plastic Surgery Combined Residency Program and completed a fellowship in oculoplastic and aesthetic surgery at Pace's Plastic Surgery in Atlanta. Our moderator tonight is Dr. Foad Nahai, who is the editor-in-chief of ASJ. He was recently named the first Maurice Jerkowitz Chair of Plastic Surgery for Emory in Atlanta, Georgia, where he serves as Professor of Plastic Surgery. He is past president of ASAPS and ISAPS. He is the immediate past president of the Quad ASF facilities, and he has authored over 200 peer-reviewed publications, 8 books, and is a well-recognized expert in this field. So Dr. Kpodzo has prepared an overview of the article, and then we can open it up for questions. For those of you who are joining us via video, please type your question into the chat box at the bottom of the screen, and it will go to either Phaedra, myself, or the whole group you can designate. For those doing audio, please email your questions to phaedra@surgery.org. And if you could refrain from putting your volume on, so if you could mute your volumes until the end when we have question and answer session, that really helps cut down on the feedback. And if you can't join us tonight, just letting you know this whole session is being recorded and will be available on the ASG website. So with that, let's have our slides, please.
Okay. All right, well, good evening. Thank you so much, Dr. Wu, for a wonderful introduction, and thank you so much to ASJ for the opportunity to discuss our paper, Malar, Mounds, and Festoons, Review of Current Management. The first thing I'd like to do is acknowledge the 2 senior authors on this paper, Dr. Sunny McCord, who was absolutely instrumental in guiding this paper, and indeed was not just a mentor for me, but for Dr. Nahai as well. And of course, I would like to acknowledge Dr. Foad Nahai, who is here with us today. I cannot thank him enough for his guidance and mentorship. Next slide. So what we want to do is first start with a quick review of the surface anatomy. And when we're looking at this disease entity, we want to be looking at looking for changes below the palpebral malar groove and above the mid-cheek groove. So here you see a figure demonstrating malar edema. That's going to be fluid that's going to collect over that malar eminence above, above that mid-cheek groove. It might be variable in severity. You may have the patient tell you that it's more noticeable after a salty meal. And on examination, you may note pitting or bluish discoloration. Next slide, please. So now moving on to the malar mound. Malar mound is a chronic soft tissue bulge or swelling. So that's the big distinction between that malar edema and the mound. We now have a permanent soft tissue excess over that malar eminence. And then moving along the continuum, next slide, please. We're going to see the festoon. Now the festoon is going to have cascading excess soft tissue, so skin, orbicularis, oculi, muscle, cascading over that malar eminence. Now, although we're discussing a disease continuum, it is important to make that distinction between the transition from malar mound to festoon, because that's really going to inform your surgical decision making, as some surgical interventions will not be efficacious in treating festoons. Next slide, please. So let's just do a quick review of the deeper anatomy, and what's really relevant here are 2 structures. the orbitomalar ligament and the zygomatico-cutaneous ligament. The former being the roof of that prezygomatic space or malar space, and the zygomatico-cutaneous ligament being the floor. And I'm sure that many of you are quite familiar with the OML, because even in performing a good blepharoplasty, you're often releasing that ligament. Next slide, please. So now we're taking a look at this in a sagittal view, and demonstrated here is that prezygomatic space with that OML above, the ZCL below, and you're able to also see two distinct layers of fat. You have your pre-periosteal fat and your suborbicularis oculi fat, your SUF, which are going to be divided by that blue, thin, impermeable membrane called the malar septum. Next slide, please. So in looking at all of this, we want to think about what the pathophysiology is behind what we're seeing. So there are two key factors here. The first would be OML laxity, and that can be primary or senile. And basically that laxity of the OML causes the tissue to slide down against the relative resistance of that comparatively stronger ZCL. Now that's going to cause attenuation of your orbicularis oculi muscle. It's going to cause descent of that lid cheek junction and redundancy of the soft tissue immediately below. The other factor that we look at is lymphatic imbalance. So that lymphatic imbalance can lead to chronic edema, which then can lead to attenuation of the orbicularis oculi muscle. Of course, in an individual patient, you might actually find that both are at play. Next slide, please. So this table is demonstrating, sorry, you can click through those, Phaedra. There's a little animation there. There you go. So the plus, next slide. So the plus signs on this chart are going to indicate the effectiveness of each procedure. So the more the plus signs are, the more it's applicable to that particular level of severity of this disease entity. So for example, in our experience, microsuction does not do much for Festoons. You're going to need a skin muscle flap with OML or a midface lift in order to adequately address a festoon. Next slide, please. So this is a clinical example demonstrating a 64-year-old female who we treated with our preferred technique of midface lift. She has moderate malar mounds, prominent eyes with a Hertel of 18 millimeters, and she was treated with a lower blepharoplasty, mid-face lift, routine canthal anchoring, and a primary spacer graft due to that prominent eye. Next slide, please. So just an oblique view of that same patient, and fine, next slide. And this being the split view of this patient at 49 months post-op, which is fairly long-term post-operative follow-up. We've, in our experience, noticed that the results last quite well in these patients. Of course, recurrence of malar edema, malar mounds, et cetera, is certainly something that comes up in reviewing the literature. Next slide, please. So let's look at our algorithmic approach to dealing with this disease spectrum. So for malar edema that's mild, we propose that you could treat that with microsuction if desired. Let's go back one, Phaedra. Excuse me. Yeah. So malar edema, if it's mild, you can use microsuction. However, if it increases to moderate to severe, then you want to add transtemporal midface lift or a skin muscle flap with OML release. Now, the key is that as the severity increases, you have to do something to address that OML and release that OML. Next slide, please. Similarly for the malar mound, if it's mild, you can consider microsuction. Certainly you're going to want to select a patient who has good skin quality. And some authors do describe adding postoperative compression to aid with the skin sort of retracting back. Now for moderate to severe soft tissue excess, again, you want to add that transtemporal midface lift to your microsuction or approach it with a skin muscle flap with OML release. Next slide, please. So finally, for that festoon, which is the most severe, for your mild cases, skin muscle flap with OML release. For moderate to severe, we prefer to use that midface lift to approach these patients. Now, for a selection of patients who are willing to tolerate a more visible scar, direct excision is also an option, although we certainly caution against over-excision and recommend considering some type of canthal anchoring for these patients as well. Next slide, please. So I want to thank Dr. Wu for this wonderful visual abstract, which I think nicely summarizes our conclusions. So I appreciate that wonderful overview. I would like to note that a recent update and systematic review by Dr. Newberry and his co-authors was recently published in ASJ that showed some similar conclusions to our study, as well as presented a more in-depth examination of minimally invasive techniques. I do see that Dr. Newberry has joined us, so perhaps he'll be able to make some comments as well. With that, I would like to move on, and I'm sure that Dr. Nahai has some more wisdom to add, and perhaps we're going to hear from Dr. Newberry as well.
Thank you, Chief. I think it was fortuitous that as we were planning this journal club, or you and I were invited to present this paper, we had just accepted the paper that you can see right there by Dr. Newberry and his co-authors, a systematic review. And I certainly enjoyed reading it, and what I'd like to do is to invite Dr. Newberry to make a few comments about his paper, and then I think we're right on time. We'll have at least 15 minutes for a discussion. So Dr. Newberry, welcome. Thank you for making time to join us this evening. If you could go over your findings through your systematic review.
Are you guys able to hear me?
Yes.
Okay. So yeah, as we kind of, there we go. Yeah, so as we kind of went through this, we'd been more interested in, a lot of patients were really not wanting to undergo kind of a more surgical procedure. They're kind of talking about more minimally invasive. So we wanted to kind of update like kind of our experience with a systematic review. So looking at it, I mean, there's kind of a broad range of things kind of going into this minimally invasive kind of selection now. Most of them, as we kind of talk about in the paper, will only really be for very mild kind of malar, like edema, mounds, and then you can, for festoons that are predominantly kind of just that skin redundant festoon, some people can consider lasers. But I think there's a paper that just came out really commentating on ours that makes a good point. Whenever you're doing laser, there's a severe redundancy of the skin. You shouldn't really neglect that canthopexy, canthoplasty, and I think some people kind of think if it's minimally invasive, you don't really think about those risks. I know we've ran into that out here in Utah a couple of times where you really can get that ectropion if you don't kind of pay attention to the lid laxity or even a latent ectropion. And so I think a couple of the ones that we don't have any experience with is really the radio frequency and the ultrasound, which, I mean, reading the papers and kind of going over kind of all of it systematically, they sound promising, but I haven't actually witnessed any of the kind of like results standard, like through multiple people, rather than everyone's always has these nice pictures to show of their couple patients that do really well. But I think still, as we kind of talk about the gold standard, typically, and what we still have the most interest in is kind of the surgical kind of applications of it, extended blepharoplasty or like the trans blepharoplasty, mid-face lift. We find better results with that. But I think one area that really the minimally invasive is going to be important and maybe going forward is that recurrence of kind of malar like edema or malar mounds over time, with a little bit of maybe more laxity of the orbital like retaining ligament, or just reoccurrence of a edema. Have you guys had much in like kind of involvement with minimally invasive yet, or kind of just stuck with the surgical?
I've had very little involvement with minimally invasive. Our experience has all been surgical. I've had some limited success with micro liposuction. So in our practice, this really, the best approach is surgical. I was remiss in not introducing you as Department of Otolaryngology in Salt Lake City, University of Utah. We're delighted to have other core physicians join us for our journal club. The journal truly is interdisciplinary, and it's a delight to have someone from the facial plastic surgery perspective join us. I have read papers in other disciplines promoting peels, promoting laser for improvement of these problems, but frankly, looking at their results, I've been underwhelmed. So I think our experience is the same, that all of us believe that once you see the changes, and your patient demonstrated it beautifully there, that surgical approach is the best option. What I'd like to do now is to go ahead and open this up for discussion. I know that Dr. Jack Friedland, our oculoplastic section editor, is on. Jack, if you have any comments to do, and we'll go ahead and open it up to the questions from the rest of the audience. Jack, are you there? Okay, very good question from Mariam Sahib Al-Zamani. Wonderful paper and discussion, thank you. Do the authors or attendees have experience with use of RF devices, microsuction for treatment of mild to moderate malar edema? This is open for everyone. At Paces Plastic Surgery and now the Emory Aesthetic Center, no experience with RF devices, limited experience with microsuction for that condition. Dzifa and Ian, have either of you had any experience? And Ian in particular, your review?
No, that is one area that Dr. Strati and then Dr. Regan Thomas, we really have no experience in the radio frequency or the ultrasound. The ultrasound kind of sounds interesting. Their claim is it's not only, whereas radio frequency is targeting that kind of dermal layer and then can get into the fat layer, whereas like ultrasound, at least the claims of it, the Ultera, is that it's going to be affecting the dermis, the fat, and down into even the SMAS and the muscles. So someone with kind of like mild redundant orbicularis, someone maybe like with like a little bit of like almost, there was a paper that came out with like congenital festoons where they have a little bit of subcutaneous fat and then a little bit of maybe orbital orbicularis like laxity. Maybe that could be useful in, but I have not had any experience in that whatsoever.
I think I would chime in the same way. Haven't really used that approach either. Mostly doing surgical.
Dr. Friedland says yes. So are you on, Jack? unmute yourself if you have any comments. Excellent question. How often do you see malar edema from hyaluronic acid fillers? Fairly often when it's done injudiciously, fairly often when it's injected far too superficial, fairly often when the improper hyaluronic acid is selected. And again, Dzifa and Ian, your views.
Absolutely, I would concur with you, Dr. Nahai. You know, those HA fillers can really pull in quite a bit of fluid, and when you're depending on where you're placing it, you're sort of worsening that chronic edema that is causing that attenuation and causing that problem. So if you put it there and it's pulling in more fluid, it actually worsens the situation. And I know that there definitely have been in the literature, and I've seen patients who have, you know, worsening edema after injudicious soft tissue filler.
Dzifa, there's a question regarding the severity of the physical exam findings, because there's a gradient of malar edema, malar mound, and then a festoon, and you've touched upon the key physical exam, I guess, maneuvers one can do, but can you kind of go over what the key differences are from your perspective?
Sure, absolutely. So I think that this is a challenging area just because, exactly like you mentioned, this is a continuum. And so the patients are typically going to start with malar edema, but they might present to you at a different point. So if we're looking at, on physical exam, a patient with malar edema, you're, first of all, for all these patients, we're looking at the distribution. So you're looking below the infraorbital rim. And above that mid-cheek fold. And you're looking for possibly pitting on your exam. You might see a slight bluish discoloration, but the key between edema and a malar mound is there's no permanent soft tissue excess. Once they have that permanent soft tissue excess that you can see a mound or a bulge in that area, then you're sort of to that point of the malar mound. Where you can extend for a pretty long time before you characterize somebody as festoon. Now, a festoon, you're really having that cascading soft tissue excess. So almost that you're seeing something, soft tissue that's now hanging over in that, in your prezygomatic space. So that's generally what I would be looking for in terms of determining whether a patient is at, you know, malar edema versus a malar mound versus a festoon.
Thank you.
I don't know if Dr. Nahai wanted to add anything to.
I have a question for Dr. Shah. He indicated that he has had experience with laser and CO2, and the question I'd have for you, Dr. Shah, is were these malar mounds, were they festoons? Was it just the early stages that we refer to as malar edema?
So for the patients that were successful, they were more in the early stages of malar edema. And I look at festoons as basically lymphedema of that triangle below the lid cheek junction and above the cheek. And something about the anatomy in that area, you know, anytime I get asked to inject filler in anywhere around the eyes, the first question I ask is about their propensity towards edema. I talk about, you know, when you cry or cut onions or whatever. And if they say yes, I actually stay far away from filler in that area because I can't seem to avoid causing myself complications, whether I use a needle, a cannula, superficial injection, deep injection. I know that if I stick to very, very, very low G prime fillers, I'm less likely to cause myself problems because I can massage and move things around so that any physical blockade of lymphatic drainage in this space doesn't get it's minimal essentially. So I stick to fat, nano-fat, micro-fat is my way of managing those areas these days. I mean, I've moved far away from filler around the eyes at this point. But we've
now, while you have the microphone, Another question was what's the end point when you do microliposuction? So instead of Chief or I answering that question, I'm going to let you answer that question. Someone has posed that question. When do you know you've done enough microliposuction or laser microlipo?
You know, I think the smart thing to do is always to think that I'm only going to get a percentage change. I'm not ever looking for full correction, because I think in that process, if I'm trying to go for what I would think is full correction, I'm going to end up with an ectropion or pull down. I'd rather come by and do, 2-3 sessions of small microlipos with overlying laser and let everything heal up on a series of small, if that's minimally invasive to most people, that's minimally invasive to me. And so I'd rather do something like that and avoid the complication, of any type of pull down if I'm not planning to do anything more supportive, like, again, a canthal suspension operation. So I'd rather do small things in series. And I had pretty decent results with, just a small little 18 gauge needle puncture, put the fiber optic underneath there at 600 microns, and just do a little bit of heating inside, break up basically what I think is deranged lymphatic anatomy, let it heal into more of a natural, maybe more normalized pathway, and then shrink wrap some of the loose skin on top, and then let it settle down over 6 months, see how much tightening I get, and if I want to, I can do a little bit more from there. It was easy. People can tolerate it under local anesthetic in the office. So that's how I look at it.
I don't know if everyone can see the comment that Dr. Friedland has made. It's in the chat box, and I think all of us are agreed that if you're going to do a complex procedure through the lower lid, the key is canthal anchoring. We have some long-term results. The patient that Dzifa just showed, which was at about 50 months back in 2014, she's close to about 9 or 10 years now. Her lower lid is in excellent position, no recurrence of her malar mounds. And at least in our hands, we've been very fortunate in that we've had less than 1% lid retraction that would require any surgical intervention. I think that, as everybody has pointed out, this is a spectrum of problems, starting with the edema, then the mound, and then the cascading festoon, where you can actually put your finger there and leave your fingers behind. You can also just imagine the fluid that's in there. And those patients, I think, are the best candidates for the direct excision. I'm going to ask Ian and then Dzifa for some closing comments. There's one other question here, Gary Tuma, feeling about orbicular muscle support and fat grafting for lower lid support. I think if you have a malar mound or festoon, you really need to deal with the underlying problem, which are the ligaments. Absolutely always muscle support, and fat grafting is a good option if you're basically dealing with an aesthetic problem rather than malar mounds and festoons where you're trying to deal with the underlying problem. Ian, are you still on?
Yeah, still here.
If you'd like to make some closing comments, and what I'm going to ask you was, when you did your systematic review, were there any surprises? Did you find anything you hadn't expected to find?
Well, the one that we have actually wanted to start trying here is the tetracycline. I think that is, especially for very mild like edema, is, I think Dr. Friedland just talked about that kind of scarring that area, that subcutaneous area, and kind of disrupting the lymphatics. So there's kind of a couple studies that show kind of more superficial lymphatics and then also deep lymphatics. So I think the idea of tetracycline to kind of just scar that area, there was no kind of infraorbital nerve damage, there was no facial nerve damage. I think I mean, it sounds promising, and I think that's one thing that we're about to maybe start trying out here for a few of the patients that have had another surgery and now just have like mild malar edema. We want to try that tetracycline in.
That's why I like the laser.
And please let us know how it works out.
Ian, I am curious about how you determine that the edema is primarily in that subcutaneous space. You know, I think that that part is an interesting part of the conundrum in deciding whether or not to try something like the tetracycline.
Yeah, and I mean that is going to be kind of trial by error, but we're hoping like with that malar septum there, it should be. We're hoping that it's kind of all impermeable. That little malar septum is impermeable, and kind of everything is superficial to that. Most of the edema would be in that layer, but I mean, there's been multiple studies that show those two kind of lymphatic layers. So we're hoping that maybe with that impermeable malar septum, like in addition, like we always need to release that, but if we don't, like maybe there could just be that subcutaneous edema, kind of superficial to that kind of area. But we'll kind of try it out. We're not really sure. We're hoping that's the case.
Well, great discussion tonight, everybody. Thank you for tuning in. We will be back next month, the first Tuesday of the month at 8 p.m. Eastern Standard Time with another exciting ASJ article. So thank you, everybody, and have a great night.
Good night.
Thank you and good night.